these questions. Now, please allow me to introduce us Mervi, who's going to give the opening remarks for this 9th session. Mervi, the floor is yours.
Thank you, Camelia. Do you hear me well? Yes?
Yes, I can hear you very well.
Yes. Okay, perfect. Good afternoon, everybody, and good evening. And my name is Mervi Hakoniemi. As Camelia already mentioned, I am the Knowledge Management Specialist of the Regional Teachers Initiative for Africa, which is a European Commission-funded initiative for teacher management and professional development. And it's my pleasure to welcome you to today's webinar in our ongoing Africa Teachers webinar series. As Camelia mentioned, this is the 3rd session of the series of Education for Health and Wellbeing. And today we will focus on preparing teachers for inclusive education, which is an area that sits at the heart of the equity and quality and transformation of our education systems. As we know, supporting teachers to reach every learner, regardless of their abilities, their background, or different circumstances, it's essential to build schools where all children can feel valued and can really attain meaningful learnings. So this webinar is part of our monthly series, and it is our final session for 2025. We are delighted to have both our long-standing participants and our new members here present. Thank you for being here and for your participation. Your insights and collaboration has been always very rich and very, very important for us. We have today 2 events at the same time. So we are also organizing at the same time a final session of the Community of Practice for education specialists. So this is the reason why the attendance might be a little bit lower today. But we will record this session and we will also prepare summaries of the interventions of all the speakers. So please stay tuned on the IGPA website. Everything will be uploaded there. I would also like to warmly welcome and acknowledge all the partners who make this series possible. And amongst these, we have, besides the European Union Regional Teachers Initiative, also the Global Partnership for Education Knowledge and Innovation Exchange, GICS, which is a joint endeavor with Canada's International Development Research Centre, the Africa Federation of Teaching Regulatory Authorities, AFTRA, the African Union, UNESCO IGPA, which manages this webinar series, and the UNESCO flagship program, Our Rights, Our Lives, Our Future, along with the UNESCO section of Health and Education and the interagency group of School Health and Nutrition. So we deeply acknowledge and appreciate their ongoing commitment on advancing inclusive education and promoting the well-being of both school teachers and the learners. So before we begin, I'm pleased to share that our next webinar series is also beginning, starting in January. And this will focus on artificial intelligence and technology in education sector. And that is, of course, a topic that has a growing importance and opportunity for all teachers and systems and learners alike. And more information will be shared soon, and we hope that we can see all of you there in the coming webinars also. Thank you again for joining and for being part of this collective. And let us begin today's session and all share the commitment and optimism and curiosity to learn more about inclusive education and the reality shared by many different children around the world. Thank you very much.
Thank you so much, Murphy. And as Murphy mentioned, we do produce a knowledge kit after each set of webinars. So after this set, as this is the final session for Education for Health and Well-being, we will produce a knowledge kit with the summaries of presentations, as well as providing you with helpful resources related to this topic. Thank you so much, Murphy. And now please allow me to invite our next speaker, Charlotte, who will give us a keynote address. Charlotte, the floor is yours.
Thank you, Camilla. So good morning, good afternoon, good evening, everyone. My name is Charlotte McLean-Ntlapo. I'm the Global Disability Advisor at the World Bank, and I'm based in Washington, D.C. I'm a middle-aged woman. I have long brown hair. I'm wearing black-rimmed glasses, and I'm wearing a pink scarf. It really is a privilege to join you today for this important conversation on supporting teachers for inclusive education in Africa. I'm really looking forward to learning from all of the speakers, all of the incredible speakers that bring such a wealth of knowledge and experience. But before we dive in, I want to set the stage for all of us. I think it's safe to say that many, if not all of us, come to this work because we're passionate about educating every child, and that during this process of our work, we have observed, or we have been a student that didn't have access to education in a way that worked for them. Perhaps it was a deaf child who was never taught using sign language, a blind child who needed Braille materials or an e-Braille, or a child who simply needed extra time to process information. It might very well have been a child in a wheelchair that didn't have access to an accessible bathroom. And all of these barriers exclude children from benefiting from education and learning. And yet we know that these students have incredible potential. What they need is a teacher who recognizes when support is needed and how to provide it. Teachers are at the center of inclusive education. While policies and resources are foundational, it is teachers who prepare and empower those that and make inclusive education a reality. Across sub-Saharan Africa, millions of children with disabilities are out of school. UNESCO estimates that only about 10% actually attend school on a regular basis. Now, we have to remember that behind these numbers are children whose potential and human capital is being lost and underutilized. And this is not because they cannot learn, but it's because the system is not ready with accessible and appropriate support. So let us be clear, inclusive education is not charity. It is a human right enshrined in the UN Convention on the Rights of Persons with Disabilities, and it's a goal embedded in the Sustainable Development Goals, Goal number 4. In addition to it being a human right, it's also smart development. When we invest in inclusive education, we invest in stronger economies, healthier societies, and in fact, more resilient communities. And it is at the heart of this transformation, are teachers who know how to adapt lessons, how to use assistive technologies, how to engage with parents and caregivers, and create classrooms where diversity is a strength. If we want children with disabilities to thrive, we must invest in preparing these teachers. I know we will learn today about some of the great work that our presenters will be sharing, but allow me to share a couple of examples from the World Bank's work on inclusive education across the African continent. The World Bank has worked with the government of Rwanda to ensure teachers were learning inclusive teaching methods as part of their mandatory, and I underscore, mandatory continuous professional development courses. In Ethiopia, over 1,400 inclusive education resource centers have been established. These centers serve as hubs for teachers to get the tools and the mentoring to improve how they teach learners with disabilities. In Sierra Leone, we evaluated the effects of mentoring and support through a community of practice that allowed teachers to discuss a range of topics, as well as have a platform to discuss challenges that they face in their classrooms. This community of practice built up the confidence of teachers, allowing them to become better teachers for students and learners with disabilities. As I wrap up my remarks, I want to invite you to be part of the Inclusive Education Initiative, a community of practice, which you can find on LinkedIn. Now, this community of practice has close to 100,000 people. Many of them are teachers who are passionate about disability inclusive education. We also have a website where you can find a lot of great resources, including reports, fact sheets, and case studies on disability inclusive education that I'm sure you will find useful in your own work. It's also a platform where we want to hear from practitioners, from teachers, what are some of the issues that you encounter on a daily basis as you work to teach learners with disabilities. So as we move into today's presentations, I look forward to learning not only from our speakers, but all of you that bring your own experiences, your own lived experience to this very important conversation. Let's take a moment to think about the one child who inspired us to join this field and challenge ourselves to consider what more we can do to make inclusive education a reality for every learner. Thank you.
Thank you so much, Charlotte. That was very inspiring, and I love how you grounded that to the single child that we're actually helping to support them to have equal access to education and thrive in this field. Thank you so much, Charlotte. Now, without further ado, please allow me to invite Quentin, Dr. Quentin from UNESCO ICPA to give the opening presentation.
Thank you, Camelia. And thank you, Charlotte. Great inspiration for all of us. What I would like to do today is to take the case of one type of disability and show from an economic point of view why it is so important to solve the issue and explain the type of programs that can be implemented to do so. We know that we need to enable all children with disabilities to go to school and learn in school, but I want to spend a bit more time on visual impairment because we have done a little bit of work at ICPA together with iAlliance, and because this is a wonderful example of programs that I think are both affordable and effective for ministries to implement at scale. You can go to the next slide, Camelia. So let me first say a few words about the need still to invest in programs for children with disabilities. We have a study. We are still going through a round of review, but we hope to make it available by the end of the month or early next month. The study focuses on school eye health, so programs for children with visual impairment. And I'm just showing here one of the graphs of the study that is based on census data from a number of African countries. And what the graph shows, without going too much into details, is that there has been progress for girls/women's education, and also for the education of children with disabilities, whether they are boys or girls. And the gaps have been reduced over time. What you see here is completion rates for primary education for different groups. And you can see that the various trend lines do tend to converge. But we still have a gap. In this case for visual impairment, and we have very similar analysis for other types of disabilities. So we still have, as Charlotte mentioned it, children with disabilities less likely to go to school, less likely to complete primary, less likely to learn. The next slide is to give you an example from Ethiopia that is based on a household survey, a recent one from 2019, and it just shows the rate of primary school completion for children with different types of disabilities. Visual impairment is one of those. And what you can see here is the comparison in orange for the primary school completion in the survey for individuals above a certain age, primary school completion for those who have a disability, and primary completion for those who do not have that specific disability, or for the last bars, any disability. And again, you can see that there are still substantial gaps. You don't always get those results when you do this analysis, but in this case, for Ethiopia, it confirms those important gaps. Now, the next slide is about the importance of being able to see well, to hear well in terms of learning. It can be shown that children with visual impairment tend to have lower learning performance. We also have the data, and we have done the same type of regression analysis for children who have a difficulty to hear in the classroom. Now, this is using PASEC data, so it's 10 countries in 2014, and I think it's 14 in 2019. What we see here is the marginal effect, so controlling for many, many other factors who can affect student performance. Does having difficulty seeing in the classroom have a negative effect on test scores? And you can see that the negative effect is there on a scale of 500. It varies between 7, 8 points to 12, 13 points. What's very important is that those negative effects of not being able to see in the classroom well, it can be visual impairment, it can also be a few other things. We have to be a bit careful, but those effects are large compared to some other effects, and I've just chosen 3. You know that if a child learns in his or her own language, the child will do better. That's a 20-25 point gains. If we have a female teacher, the child will do better. If a child is in a rural school, the child will do worse. But what you can see here basically is that what we can measure as a proxy for visual impairment has impacts of a magnitude that is similar to many of the other effects that can affect children's learning. There is also a lot of studies which are using randomized control trials or other experimental approaches that do show that providing eyeglasses to children with visual impairment can really improve their performance in school. Now, the next slide is just to give you a few more stylized facts before I make the argument about the fact that programs to solve those issues are affordable and have high benefits to cost ratios. So the stylized facts is that in many countries, children who have visual impairment are the largest group of children with disabilities. It's not the case everywhere, but it's the case in many countries. I'll mention later also that this is the fastest growing disability for children, right? I mean, in many African countries, we see in the data rates of visual impairment of about 1 to 3%. 1 to 3% of the children have visual impairment. In some Asian countries, the rates are 20-25%, right? In the US, in Europe, the rates are also much higher than in Africa. And those rates are rapidly increasing, in part because more screen time, sometimes even more reading, being more indoor. All of this tends to have a negative effect on the ability of children to actually see, right? Well, so visual impairment is a major issue, and it's a growing issue. The cost of intervention in what we call school eye health programs, I'll explain what that is, are actually very low and lower than the cost of many other interventions for children with other types of disabilities. We also know, especially in Africa, that many countries have very low coverage rates for those school eye health programs. It was not a question asked in PASEC in 2019, but in 2014, we had about 5% of the students in grade 2 who were screened for visual impairment. In grade 6, it was 7%. So these rates are very, very low, and limited progress has been achieved over the last 10 years or so. And then we know from many experimental data that providing school eye health programs can help the children. So what is actually that? So it's very simple, right? The teacher can screen the children in the classroom with a little bit of training to detect visual impairment. Many of us, when we were kids, we may have had to read letters on a wall a number of meters away from us, and that's a very good test. And the teachers are very effective. About 95% of the cases of visual impairment can be detected through this kind of test by a teacher, right? So we just need to train them a little bit to do that. And then for most of the children with visual impairment, 80-90%, that depends on the conditions, the country, and so on, we know that providing a very cheap pair of eyeglasses can solve the issue. And I mean, the glasses that I'm wearing today, these are $2 a piece or something like that. They are very cheap, and they're effective. And for African countries, there are also foundations that can provide those glasses free if those countries are considering expanding their programs for school eye health testing, screening, and then providing glasses. And then, of course, for some children, we need a more involved intervention, and then we need a referral to the health clinics. But basically, we know how to do those programs, we know they are effective, and we know they are low cost. The next slide will enable me to start talking about the cost-benefit analysis, and I think I may have about 5 minutes left. So when you do a cost-benefit analysis, you try to look at the cost of programs, and then you try to look at some of the benefits at least, and then you do a ratio. And the hope or the justification from an economic point of view of a program is that the benefit to the cost is high. Of course, there's also a human rights argument that we should do this, and we should enable all the children to learn. So let me go to the next slide and mention some of the issues of costs, right? There are different studies that have been published in the literature. Two were very detailed on Cambodia and Ghana. And the cost of implementing those programs, those school eye health programs, was estimated. If the training was provided to teachers every 5 years, we had a cost of about $1.5 to $2. It's pretty similar between the two countries. That is what is shown in the table. At the same time, a good chunk of that cost was providing training to the teachers. And it would be very easy to embed the training that has to be provided to the teachers to screen the children. We can embed those few hours of training into a larger training, and then there is basically no cost for the training of teachers. And as I mentioned, the spectacles is not the largest part of the cost. The spectacles that are given to the children who need them can also, for low-income countries, probably be obtained for free for different foundations, and some of my colleagues who will present later can explain that. then you would get a cost at $1 to $1.5. And if you think also that when you have those pilot programs, the coordination cost at the level of the ministry is a bit higher than you would have otherwise, and you might be able to avoid most of that coordination cost when you scale up, and that's not an out-of-pocket cost probably. I mean, the staff in the ministry are there. You get to a cost that is about $1. Now, we did interviews, among others, with the Brian Holden Vision Institute Foundation. There is also data collected for Liberia, and that cost of $1, a bit more than $1 per child, seems to be a good benchmark. This is not per child with visual impairment. This is per child who is screened, so all the children in a school. But $1 per child seems something that countries can actually implement at scale. The next slide then goes into some of the assumptions for the benefits. And we don't have a lot of time. We have a study coming up. We also have a more technical paper. There are different assumptions that we use. Basically, we try to understand what would be the impact for the child who is visually impaired to have the pair of eyeglasses, essentially, right, or the treatment. How much would that improve learning for the child? How much could that improve the likelihood that the child stays longer in school, has higher educational attainment? And we use assumptions that have been used at the World Bank that are actually a little bit conservative, especially in terms of the returns for education on the labor market. I won't go into the details, and I'm happy to answer questions in the Q&A. Now, the next slide shows you some of the benefit to cost ratio, right? So we look at the benefits for the child in adulthood of having been a beneficiary of a school eye health program, and we compare that to the cost that I mentioned before. And these are the benefit to cost ratios. It depends, of course, what you assume as cost. And the further reduced cost is the last one that I mentioned, the one at $1. In Cambodia, we would have a benefit to cost ratio of 10, in Ghana, 5.9, in Vietnam, much higher, 26. Now, there are differences between countries, right? And there are different reasons for those differences. One difference is that the expected earnings of a child are very different depending on where the child lives. That's one type of difference. Another difference is what's the share of the children who have a visual impairment issue, right? In the classrooms. In Vietnam, as I mentioned, that's one of the Asian countries where you have a much, much higher share of children who need eyeglasses. And that means that the cost is not much higher, actually, to serve those children. And so since the cost is not that much higher and you serve many more children, then you have many more benefits, right? And the benefit to cost ratio is higher. Now, those type of calculations have a lot of assumptions. We understand that. Some benefits here are not accounted for. For example, girls benefit a lot from educational attainment in terms of issues related to fertility, decision-making, labor force participation, even the health of their children, et cetera, that's not factored in. The health benefits are also not factored in. The bottom line, the core message is that school eye health programs and also some other types of programs for children with disabilities have high benefit to cost ratios. Now, the next slide, I think, is my last slide. This is my conclusion. I just want to say that there's a high need for school eye health programs and, of course, other types of programs for children with disabilities. But school eye health is also very much needed because, as a reminder, as I mentioned, visual impairment is the fastest growing disability, right? And we can expect it in the next 10, 20 years to increase in a very consequential way in African countries. We need to do something. Those programs, the school eye health programs, are low cost. At $1 or maybe a bit more than $1 per child screened, you can get this done. This is something that is affordable for a ministry or another organization to do at scale, even in LICs, in low-income countries. We have high benefit to cost ratios. So apart from being the right thing to do, it's a very smart investment. And then the last thing I want to say is that there's a lot of experience in those programs. We have experienced NGOs that can help the ministries to implement. I mean, many countries have organizations that have already done small-scale programs. We also have groups like the Eye Alliance, which is more of a global expertise groups, but there is expertise to help the ministries implement this. And so our hope is that many, many more countries will be convinced and will start implementing those programs, and starting with School Health. And we'll have another presentation later on for children who are with hearing impairment. I mean, with these programs, we can start to implement that at much larger scale. The last thing I will say is that at IGBA, we are developing a number of resources. They should be available early next year. One of them, for example, is a manual for teachers that does not focus only on school eye health, but more broadly on inclusive education for children with disabilities. And we will make all of that available together with the knowledge kit that will be prepared after this last of 3 webinars on education for health and well-being. Thank you, Camelia.
Thank you so much, Quinten, for giving us a broad overview about how effective these eye health programs could be, and the cost benefits analysis. And as Quinten has mentioned, we have Elizabeth from Eye Alliance to give us a more thorough dive into the program of eyeglasses itself. So Elizabeth, please, the floor is yours.
Thanks so much. Thanks for hosting this really important conversation. My name is Liz Smith. I am co-founder and CEO of Eye Alliance, and I'm excited to be here and share more about the potential to deliver glasses to children who need them. So let's start on the global map slide. The next one, maybe. One more. Yeah, let's start there. So globally, there are about 1 billion people living needlessly with poor vision because they don't have access to a pair of eyeglasses. Now, this has negative impact on learning outcomes in children. As Quinten mentioned, it has negative impact on productivity in adults. It affects road safety, and it even limits access to the digital economy if you can't see your phone in front of you. Next slide, please. I founded Eye Alliance 10 years ago to activate and drive scale strategies to bring glasses to those who need them. Now at Alliance, we demonstrate the viability of new scaling pathways, and we do this by activating underutilized government and private sector channels. We enlist new actors to influence funding flows and shift priorities, and we are equipping governments, entrepreneurs, and investors with the roadmaps, the tools, and the expertise they need to turn proven models into scaled solutions. Next slide. During our first year at Eye Alliance, my co-founder and I, we went on a listening tour to understand what other eye care NGOs, from their perspective, what was working. My co-founder and I were at an organization doing direct delivery of eyeglasses, but we knew it was really important to gather other perspectives. And it became clear very quickly on in those conversations that the one intervention that all the NGOs agreed, all the eye care NGOs agreed was working, was school-based vision screenings and provision of eyeglasses, or school eye health. And this makes sense that schools would be an appropriate platform, because myopia, which is the condition where objects appear blurry in the distance. Myopia is often diagnosed between the ages of 8 and 12, and it usually gets worse during adolescence. The good news, as you've probably assumed by now, that myopia is correctable with a pair of glasses. But without that correction, children can't see that blackboard clearly. And I was one of those children. Myself, I did not get glasses until the 3rd grade here in the US. And before that, before I had my glasses, I couldn't see anything on that blackboard, and I was just pretending to copy notes. I didn't know that was the problem I was having. I just thought that's the way everyone saw the world. Next slide, please. And so as Quentin mentioned, this is a really straightforward intervention and very well proven. Step one is training teachers to conduct a very basic vision screening. And I think it's important to note that they're not diagnosing any vision problems. This is just a basic screening to determine whether children's eyes are healthy or not. And if their eyes are not healthy and they need to be seen by an eye health professional, then those eye health professionals come to the school, they conduct and perform a comprehensive eye exam right there in the schools. And then those eye health professionals will determine the child's prescription if they need a pair of glasses. And like Quentin mentioned, about 86% of children who will need eyeglasses that day can get them on site, delivered by that eye health professional right there in the school, because there's been an innovation with glasses where you can pop in lenses into these frames, and so they're able to address a large number of the need right there on site in schools. And then for those children who have more advanced eye conditions, the eye health professional will refer them to the appropriate facility for the care that they need. Now, I just want to point out that this model was innovated by eye care NGOs decades ago. I mean, this has been iterated and refined over the years, and there is a lot of evidence generated by these NGOs that teachers can do the screening, and they do it well. And the training, it can take as little as 3 hours. It's not a very burdensome training process. Next slide, please. Now, there's been numerous studies in RCTs that have proven that correcting poor vision with a pair of eyeglasses can both improve learning outcomes and test scores. But, simply put, glasses are ensuring that children who live with poor vision have the same opportunity to succeed in school as their peers. And again, I'm one of those who can attest to that. Next slide, yep. So let's look at the numbers. Quentin touched on these as well, but the WHO estimates that there are over 300 million children who have myopia globally. And as he also mentioned, those rates of myopia are on the rise. And if current trends continue the way they have been rising, by the year 2050, about half the world's population could be developing myopia. Next slide, please. Now, as I mentioned, NGOs have played a really critical role in pioneering and iterating this intervention. But they won't be able to scale to meet the need. That's just not a possibility. So government must be centered in the solution. And it's iAlliance's theory of change that if properly supported, ministries of education and health can and will become the implementers of school eye health, and that they're also willing to allocate funding to help achieve a national scale of these programs. Now, in 2028, iAlliance met the then sitting president of Liberia, President Ellen Johnson Sirleaf, and Mike, you can take it to the next slide. My co-founder and I, we were planning to talk to President Sirleaf about creating access to reading glasses for adults. That was what we had planned to pitch her on, but she very quickly sort of stopped us and said, no, I really want you to prioritize the children in schools who need glasses. And President Sirleaf is a glasses wearer herself, and so it was something important to her. So she'd asked us to work with her two ministers, her Minister of Health and her Minister of Education, to create a plan for school-based vision screenings and provision of eyeglasses. And it was there in Liberia, working alongside the Ministries of Health and Education, that we at iAlliance learned really firsthand what it will take to embed this intervention that was innovated by NGOs and what it will take to embed that intervention into government systems. Next slide, please. So iAlliance, we're a very small organization, and we can't be in more than one country at a time. And so what we decided to do was systematize this work. And so we've created a suite of resources. We've developed integration workshops and labs to help facilitate replication of this work that we began in Liberia. And I want to point out that in addition to our materials that we've compiled, just this year, the WHO released both a manual but also a digital training module that can be used to train teachers to screen for hearing and vision problems. And so this digital training module, it has the potential to even further simplify the training process and the potential to reduce costs even further. So it's exciting future. Yeah, thank you. In 2022, iLiance enlisted the Clinton Health Access Initiative as a partner of ours. Now, that organization has a really great track record supporting ministries to add new service offerings. They have offices in over 30 countries. But traditionally, that Clinton Health Access Initiative, they have stronger relationships with ministries of health. And this work is really most effective when it is co-owned by both ministries of education and health. And so that's something we've been supporting them with. And I know Commissioner Sarah is here and can speak to Uganda's groundbreaking work with School Eye Health. But I will just say that they are real leaders in the space and showing us what's possible with when ministries are taking the lead. And it's been really exciting to watch the progress they've been making in Uganda. iLiance is also working with Clinton Health Access Initiative in Ethiopia. We are working alongside the Ministries of Health and Education to lay the foundation for school-based delivery at national scale. And I also just want to note, because there has been a lot of interest in this work, and I just wanted to note that there are the ministries of health in South Africa, Tanzania, and Nigeria have all been interested in working on this bringing these important programs to their children, and they've drafted national plans. So, in summary, there is obviously a lot of important work to be done with inclusive education, and this is something we all know that. But we know that School Eye Health works. It's been proven again and again that this intervention works, and that governments are the right entities to be implementing this work at national scale. And as Quentin pointed out, it's a relatively affordable intervention, and it can be rolled out very quickly by ministries to have a real immediate and powerful impact on learning outcomes in children. Thank you.
Thank you so much, Liz. That was very interesting. And also, fun fact, I'm also a myopia person, and I started having glasses since 5th grade, I think. And that really helped me to see the board no matter where I sit in the classroom. So yeah, and it's glad to hear that the teacher training program can be as short as 3 hours to equip them to have that knowledge and skills to screen children with visual impairment. And I was wondering, for our participants' sake, is there a way to contact you if they're interested in more about the program?
Of course.
Maybe you can drop your email in the chat, and that could help. Thank you. And next, I believe our speaker is here. We also have Mr. Muka from Zambia to introduce to us how Zambia has been implementing this inclusive education into its education system. Mr. Muka, can you hear me?
Yes, please. Thank you.
Okay, yes, please go ahead.
Am I audible enough? Okay.
Yes, we can
so
hear you.
Thank you
clearly.
very much. Yeah, thank you very much. Enhancing teacher capacity in inclusive practices as a shared vision with the Regional Teacher Initiative for Africa has really been something that the country has embraced with greatness, because we are tapping one area in the entire universal set of inclusive education, and with a focus on one subset, which is really has been neglected for some time. And so we have done a lot of programming around there to focus on that subset so that we see how we can do the disability inclusion to complete the whole set of inclusive education practices in the ministry. So the next slide. Yeah, that is just the presentation outline. We move on. Okay, so in our country, inclusive education sits so well in all programming, in the sense that in the 8th National Development Plan and all the other supporting policies, this is seen as a program. And when it is a program, it means it should be mainstreamed in all the other areas of the educational processes. Next. Next slide. This was the 8th National Development slide. We see the ministry picking up and trying to translate how this can be feasible by emphasizing that we need a cadre of teachers who are going to focus on ensuring that learners with special educational needs and disabilities are programmed in all the areas from ECE to tertiary education. Next slide. So, what is it that compelled us to begin focusing on this? As a national needs assessment that has been conducted in school monitoring, teacher consultations, policy reviews, we came to discover that we have a lot of unclear operational inclusive education standards that are there around all the practices within the country. And we also established inconsistent teacher preparations for disability inclusion. No wonder this cadre of learners, teachers still have a problem to actually fully include them in their teaching. Not forgetting also insufficient assistive technology integration and the fragile administration support to teachers. So now all these realities have directly informed the technical teacher assistance design under the Regional Teacher Initiative to see how we can make this teacher a well-informed and ready teacher to actually get into the full programming of embracing all learners so that no child is left behind. Next slide. And so the problem statement, as Area alluded to and outlined in the background, really our current education framework is anchored in policy, very good policies, yet teacher and leader practices readiness are not fully actualized, resulting in the underlisted areas of inconsistent disability accommodations, absence of structured teacher support, low assistive technology uptake, burnout linked to unclear inclusive delivery expectations. And so these, we are saying, if it happens so, teachers will actually not be performing their duties according to their expectation. And even leadership, still a problem. And so all these informed why we needed the technical assistance. Next slide. Okay, so I will not spend much on this because I think I've already spoken to this. But in a nutshell, we can say each of these areas, lack of unclear operational inclusive education standards led to us seeking a technical assistance to review our implementation guidelines. They are a problem. So then, also the teacher preparedness for disability inclusion. Here we are talking about issues of sustainability. We are focusing on the teacher. If we have an updated modules and teachers are trained to focus on pedagogy, I think the sustainability, if it starts with teacher education, the colleges of education and universities, then we know we are going to be sending a cadre of teachers that are ready for interventions. Next. Yes. Assistive technologies and our administrators, what we came to discover through our monitoring systems are that when you monitor, you find this head teacher is trained in a secondary, has got all secondary background, does not understand how the learners in the primary school should be actually handled. And so, because of qualifications, someone in the secondary background say to go and be an administrator in a primary school, that becomes a problem. They do not understand how these learners and how the teachers should support the learners. That is a problem. And hence, we thought of having a technical assistance focusing on helping these administrators to actually be capacity built in that area. Next slide. So really, the needs assessment. This needs assessment, when you look at it, the sources and the extracted needs are what speaks to why we felt we needed to share this vision and see how best we can actually work around them so that we find solutions. School monitoring reports, teacher professional development index baseline, consultations with teacher colleges, and also discussions with special educational units and administrator feedback all provided the sources to inform our need for the technical assistance. Next. So in technical assistance 1, which is actually evidence informed, that teachers lack unified guidance and implementation clarity, resulting in stress sometimes and inconsistencies, creating equity gaps. We thought of envisioning actions where we could review our existing implementation guidelines, so then we can disseminate the revised guidelines and train all provinces. Of course, the expected research-based impact would be to improve quality, reduce teacher emotional fatigue. When teachers don't know what to do, there is a lot that grows an emotional fatigue around them and performance is reduced. And then also standardizing accommodations to strengthen the need for enhancing their practice. Next. So in the technical assistance 2, evidence informed that teachers require modernized disability responsive tools and technology integration to reduce workload strain and learner exclusion. We need to tap into technology, help the teacher use technology to prepare for either identification, assessment, screening, and referral mechanisms. So we need to update existing training modules, especially for learners with hearing impairment, because they are one group who are giving us a problem to fully include them in the mainstream. Then we integrate technology with inclusive pedagogy and pilot the new modules. Expected impact here is to improve teacher competence and confidence, and easy access and informed solutions through technology. Hence, reducing instructional stress. Next. In the technical area 3, the leadership, like I earlier alluded to, whose evidence-informed need is that school leaders lack procedural guidance to support inclusive teaching practices effectively. And so actions are to develop an administrator manual for in-service inclusive supervision and train education administrators to support and monitor the teachers. The expected impact is that we will have a strengthened school support system to enhance teacher wellness culture and reduce burnout due to structured leadership presence. So all these provide an envisioned, informed, shared vision to actually actualize the inclusive practices in a manner that they are going to give us the results. And in concluding, the next slide. So, okay, that's good. Maybe the previous slide. Okay, so where we as Zambia, we did, we presented our expression of interest and designed the country action plan. And currently we are at implementation. I think the next week we are beginning to evaluate the technical assistance one, because we have already started doing data generation and getting a lot of information just to triangulate and make sure that we prepare the guidelines before the technical assistance too. And in all this, we have not left the organizations of persons with disabilities and all the other people that are actually involved in enhancing their welfare. We move next. So in concluding, we are saying the needs assessment outcomes confirm that strengthening inclusive delivery requires an integrated approach where our updated guidelines will inform the teacher disability specific capacity building and empower institutional leadership. These three pillars, in our view, will actually reinforce teacher wellness, disability accommodation, and systemic uniformity, ensuring equity and professional sustainability. And the model we are trying to embrace is not using a cascade model, but capacity build all teachers. Thank you so much.
Thank you so much, Muka, for your wonderful presentation. And we see like how Zambia is comprehensively through these three pillars to strengthen the capacity of the education system to accommodate to all students, including the one who have special needs. Next one, we've talked a lot about eye health. Next one will be a program for the deaf children. Please allow me to welcome our speaker, Vincent, and his sign language interpreter. Vincent. And Susan.
Yes. Hi, everyone. I'm very pleased to join this wonderful webinar, and I'm seeing a lot of great work happening around in the area of education, and I'm happy to learn a lot today. As mentioned, my name is Vincent. I'm from Ikitabu, based in Kenya. And for inclusiveness, I'll introduce myself. I'm wearing a white t-shirt and a black watch. I am also wearing a Kenyan bracelet. I am slightly big. I have black hair and I'm dark in complexion, and have an interpreter called Susan Thuo, who is here with me and will be voicing for me. So at Ikitabu, we are an EdTech company, social enterprise. We are working to deliver accessible, inclusive content for learners to achieve inclusive education for all.
Thank you. Susan, may I ask Vincent to turn on his camera?
A minute, please.
Thank you.
Yes, we can see. Sorry for that. So maybe we can go back to the first slide. So yes, at Ikitabu, we are implementing a project called Scaling Inclusive Early Learning with deaf children. We are working with a consortium of 3 other partners. We have Open Dev Education, who are leading in the research of design of the research questions and cost effectiveness. We're also working with Kentaris International, who are supporting us with bilingual expertise and also with engaging the parents. We also have another one called Busara, helping us to evaluate the impact of our work. We're also working with other organizations of persons with disability in Kenya. For example, Kenya National Association of the Deaf, that is for Kenya, and then Rwanda and Malawi National Associations of the Deaf. Yes, in the 3 countries. Now we can go to the next slide. So for today, this is what I'll be talking about. I'll give us a project overview. I'll talk to us about sign language rich environment and what it means. What is the aim of our project? Any documented evidence that we have in the area of sign language work as we scale this work, and how we are strengthening the capacity of special needs education, working with parents and also caregivers of deaf children. And lastly, any contribution that we have and recommendations for informing any policies in the 3 countries that we are working in. Next slide. So when you talk about our sign language rich environment, from our previous pilot project in 2021, we started this in 2 schools of the deaf, and we learned what a sign language rich environment means. Number 1, we have a fluent deaf teacher supporting the learners in the classroom. Number 2, we provide accessible learning materials so that the children are able to understand them in their own language. We have also supported the teachers with teaching knowledge, that is through training. We also assess the impact of the work. And lastly, we are engaging the parents because parents have a responsibility with their child's education. Next slide. So far, we have been working with over 200 teachers. I've been able to train over 200 teachers in Kenya, Rwanda, and Malawi as well. That is teacher capacity building. We have also reached over 3,000 learners. Specifically, I'm referring to deaf learners. We have also assessed over 1,000 learners. And we have also been able to reach over 150 parents in Kenya, Rwanda, and Malawi. We have also produced over 260 learning materials in Kenyan Sign Language, Rwandan Sign Language, and also Malawi Sign Language to support the learners in their studies. Next slide. So how do we support teachers for inclusive education? We can go to the next slide. First of all, we'll start with the challenges. We have seen a lot of challenges in the 3 countries where we work. For example, we say that there is a late screening and referral, as mentioned before, whereby if students are screened late, then they also join school late, and that affects their education. There's also limited training on special needs education and inclusive pedagogies for these teachers. We also have inadequate teaching and learning materials for the deaf learners. Some of the countries have very huge classrooms where the teacher is not able to meet the needs of each and every learner, depending on their different disabilities. The teachers who have been trained in special needs education are also very few. and also there is lack of inclusive curriculum. So those are some of the challenges we have found when implementing this project in the 3 countries. We can go to the next slide. In the 3 countries where we are working, they each have a policy that supports and promotes inclusive education. For example, in Kenya, we have the Special Needs Education National Policy Framework of 2009, which focuses on special education. We also have the sector policy on learners and trainees with disabilities of 2018, so that are available in the area of education. In Rwanda and Malawi, they also have the same special needs inclusive education policies and national inclusive education strategy. We can go to the next slide. As I previously mentioned, yes, the 3 countries have policies that encourage special education. And so what are we doing as Equitable to help us, or to help the learners and teachers realize inclusive education? One, we produce and distribute accessible learning content, that is sign language and also in Braille to support the learners. We also have easy to read content to support the learners to be able to participate fully in class. We also have we have reached over 200 teachers through teacher training, empowering them with different capacities and teaching pedagogies for teaching learners with disabilities, and also how to care for them and to support them to acquire and improve in their language. We've also built a community of practice. That means once a teacher learn or are trained with us, then they're able to train other teachers, spread the same information. We have also employed deaf teachers within these schools in early grade levels. So far, we have supported over 46 deaf schools in Kenya, Rwanda, and Malawi, and have teachers who are supporting those learners. And parents' engagement through parents' awareness workshops. This is something also doing in the 3 countries. We train the parents on how to care for their children while they are at home, because we realize that they need to be aware of their child's needs, and life becomes easier for their child and able to participate fully in class. We also have inclusive assessment. We train the teachers on how to assess a child so that they're able to realize what gaps are these children experiencing and how am I able to support this child. Next slide. From the work that we have been doing so far, we cannot be able to achieve this alone. We cannot be able to realize all the solutions alone. So we need to work with the government, other education sectors, and other NGOs who share similar ideas. And as I mentioned, implementation sometimes is the hugest gap. The policies are available, but we do not have proper implementation. So that is one of the things that we emphasize on, policy implementation. Then training opportunities and recognition of qualified teachers to promote inclusion. So for teachers who have disabilities, can they be empowered and be sent or be empowered to train those learners so that the learners can fully participate and learn from the best? Engaging the parents and the community as well. As we mentioned, the parents have a huge responsibility in their child's life, especially a child disability. They need to know, how do I support them? How do I make the teachers' work easy? Is a parent aware of how to support their child in different ways? And also having resources, enough resources. The government need to provide resources to achieve inclusive education. That means it comes with a cost. And in the 3 countries, one of the things we're emphasizing is to have resources for the classroom. That could be books or even other materials required in the classroom. And the last slide. Yes, and with that, I want to thank you very much for this opportunity.
Thank you so much, Vincent. Thank you for this presentation. And I've already seen a lot of interest in collaboration with the Equitable for the program. So we can chat more in the Q&A session. And of course, you're more than welcome to leave your emails and contact Kitapo for knowing more about the program. So one of our speakers, Sarah from Uganda, she is unable to join us because of connectivity issues, but I believe Quentin is here to present a little bit about the iHealth program in Uganda on behalf of Sarah. So Quentin, are you able to share your slide?
Sure. I can share a few slides. I talked to Sarah this morning, and she's in an area where there is no electricity right now, and that's why she did warn me that she might not be able to join. I mean, there were different things we talked about, and she was preparing something about government policies. What I wanted to, and I gave her a few numbers for Uganda. Maybe what I want to do is very, very short, but mention one potential resource that can be useful. You can see my screen, right, with that one slide. Can you see that,
Yes, but
Camelia?
can you
Okay,
put in
great.
the presentation mode?
It was in presentation mode on my screen, but apparently it doesn't seem to work. So I'm
it's
just going
okay.
to make it a bit broader on my, like that. Okay.
That's perfect.
The point I wanted to make, and Sarah would have done a much broader presentation, but just one suggestion is to use all of the data that are available about disabilities. What you have here that you can see on the screen is a map based on census data with the so-called Washington questions asked in the census. And this map shows the prevalence of visual impairment for children aged 7 to 13. And you can see that in the various districts in the country, you have actually pretty different rates of visual impairment. I mean, I can just perhaps also show the same thing for this is multiple disabilities, this is mobility, and I'll just go one slide up. And this one is about hearing difficulties and mental intellectual difficulties, right? Let me go back to the visual impairment. So why does that matter? I mean, we obviously want, whenever it's feasible, countries to implement programs, whether programs for school iHealth or programs for children with hearing disability or other types of disability. We want this to be national, but at the same time, we have to realize, especially for some types of disabilities, that implementing a national program can be costly, right? And not all ministries have always the resources needed to do that at a national scale. And I just want to mention that I believe there are ways of optimizing the resources when those resources are limited, right? When you target areas where the prevalence of disability is higher, with the limited resources that you have, you're going to be able to reach probably more children. Even more important than the prevalence, it is in each school. If you have information on the rate of different disability, then if you have limited resources, you could try to target first the schools that have the largest number of students with a specific disability, right? I mean, again, we want to reach everybody, but when there are limits, at least you can try to maximize the impact of your program by targeting schools. So we did a little exercise. This is not on this slide, but I wanted to mention it with data from Ethiopia. Ethiopia has a very nice EMIS, Education Management Information System. They do ask about whether children have different types of disabilities in the annual questionnaire that goes to the schools. And as a check, we wanted to see whether those data were somewhat reliable. And so we did cross the data that we got from the EMIS survey by geographic location with data from a household survey, completely independent, where we also have the Washington group questions, and so we also have estimates of prevalence. And what we could see is that there was actually a pretty good correlation. So the EMIS data, when we ask questions on disability, are not perfect, but they are useful. And then what you can do is show how much more bang for the buck, to take an expression in English, how much more impact for every dollar you can get by targeting first the schools with the largest number of children, in this case with visual impairment, right? You have to send a team, you have to test the children, you have to provide the glasses, and all of that is cheaper per child when you have schools with a larger number of students and more students with disabilities. So I just wanted to mention that as one very small suggestion. The other thing that we did in the case, maybe I'll show that, in the case of Uganda with Sarah, is that in this slide we computed what would be the cost of implementing a national program for visual impairment. This is the bottom table there. Whether we go to all the public schools or all the public and private schools, and different assumptions, whether the training, a few hours, as was mentioned, can be embedded in another training. And this can be very useful to see how much it costs to go nationally, and then how to compare that with resources from a World Bank loan or from a Global Partnership for Education loan, etc. We are happy to do that for other countries. Let me stop sharing. There was in the chat a gentleman from Côte d'Ivoire who told me, how can we help Côte d'Ivoire? We can actually do this kind of analysis, looking at the prevalence of different types of disabilities, looking at some of the benefits of programs, looking at the cost of implementing those programs. All of that is feasible with the data that is available. And we are happy, depending on the requests we get, to do those kind of technical assistance analysis, if we want to call them that, so that we can help countries move forward. We are actually doing this right now for Ethiopia, and we hope that this is useful. Again, if you have questions or requests, let us know. We don't guarantee we can do it, but we will do our best to respond to all the requests we get. Back to you, Camelia. And again, I apologize on Sarah's behalf, because I know that she was in an area with no electricity, and her batteries on the phone and the computer was going down even this morning. Thank you.
Thank you so much, Quentin, for presenting those numbers, and I believe that's very helpful for our audience. Now, without further ado, I saw a lot of great questions in the chat and in the Q&A. So allow me to invite my colleague Yvonne to facilitate the Q&A session. Yvonne, please.
Thank you so much, Camelia, and good afternoon, everyone. Thank you to the presenters as well. I have learned a lot from this session, and I believe the participants have learned a lot as well. I learned from Quentin about the various disabilities that tend to interfere with schooling, and including school completion. And I was shocked to know that there are over 300 million children who have myopia. As one of the people who have been wearing glasses since grade 6, that comes as a shock to me that there are so many people. But I was also excited to hear that there's a training that can happen, and this will only take 3 hours to enable teachers to be able to at least recognize or identify those children who are having sight issues with their sight. I think if we had this in my time, maybe I would have been assisted earlier. So thank you so much. It's been a great session. And we also have a couple of questions from the audience. So I'll just read what has been there. And if we have time, then we will have, we'll open the floor for participants to also just ask directly. So the first question, and this is from Michael. Michael says, with the rise of technology in education, what are the most effective low-cost assistive technologies or digital resources that can be immediately deployed in a resource-constrained environment like many schools in Uganda? And also, what are the key funding and resource challenges for institutions like Nabumali School of the Blind? And what practical steps can the ministry and international partners take to ensure sustainable infrastructure and specified equipment. So that is, I think that was directed at Quentin, and I'll also read another one that was directed at Quentin. We observe that generally there's no feedback on cases referred to specialists after serious conditions have been detected in the classroom. What remediation strategies can we develop to save children with serious conditions in our schools? And this was directed to Dr. Quentin. I think, I'm not sure, but I suspect you have responded to this. And I'll give the third question, and then maybe we can respond. Then I give another set. So this is from Vaiju. Please forgive me if I pronounce your name incorrectly. I really like the expression community of practice. First, I would like to ask you how we can know that a student is suffering from a disability. As an educator, should we refer to their consultation card? Should we give them special attention even though there are 43 students in the classroom? Also, do you think a pediatrician should be assigned to each school? This was actually directed to Mavi. So please, over to you. Then we'll take the next set. Quentin, maybe we could start with you.
Sure. And Yvonne, I'm sorry, but I got the second question, which was about the serious conditions. But the first one was what? Again, because it was very long and I forgot. You're muted, Yvonne, or I don't hear you.
Okay. So the first question is, with the rise of technology in education, what are the most effective low-cost assistive technologies or digital resources that can be immediately deployed in resource-constrained environments like many schools in Uganda? That was the first question.
All right. I mean, I can try to answer, right? But on School iHealth, I mean, Elizabeth from iAlliance knows much more than I do. Let me just say a few pointers. And there was also a question in the chat. So my first pointer was about the training of teachers, right? And we had Vincent also mentioning some of what they're doing, as well as the Zambia experience separately. I mean, we need to provide training to teachers. And I think the issue of digital technologies here comes very strongly. I think that on many aspects of inclusive education, including disability, we should try to have training in person, embedded, as I mentioned, but we also should try to make resources available online. What I mean by embedded training in person, and there was a question in the chat, I take the example of Ethiopia, right? I think they have this very nice program where for 3 weeks over the summer, they bring 80,000 teachers in 40 locations across the country. They use universities. They do that over the summer because the cost is much lower, right? I mean, the students are not there, so they can use a dorm. And then they provide training for 3 weeks on many different topics, right? The additional cost of putting a few hours on disabilities, if it's School iHealth, a bit more, if it's broader, is almost zero, right? And that's why I'm saying we can avoid the cost of training teachers if we think carefully about how to embed that. And I would also say that we can provide e-learning resources for teachers. And at ICBA, we are trying to expand our e-learning. And what I can say perhaps today is that I think we haven't not done yet an e-learning course on introducing teachers to several aspects of providing better opportunities for children with disabilities, but we could do that. I mentioned we are finalizing a manual that's in French for Francophone countries on inclusive education for teachers. We can turn that into something that is online. And the last thing I want to say about online and digital resources is that we can make those things, at least for the teacher training component, available in schools without the internet, right? There are ways of doing that which are actually pretty cheap. Of course, there are broader aspects of digital technologies, including, for example, for the blind, but maybe I should not go there. The second question to me was about the referrals for serious conditions, right? I mean, as Liz said, about 85, maybe more sometimes, % of the children with visual impairment can be getting the solution with a pair of very cheap eyeglasses, and those can be sometimes gotten for free. But you do need also, of course, the health clinics where you can provide referral, and that's for very few children, but this is needed. And I don't know if Liz wants to say something more on that. And then on the last thing that you asked me before giving the floor to the others is to identify children with disabilities, right? I mean, for visual impairment, there's a simple test. For other things, there are also some tests, but there's a broad education that has to be given to teachers. And I wonder if somebody did not put in the chat the issue of stigma, or maybe it was in a Q&A, and the fact that, for example, some children don't like to wear glasses, right, because there's stigma associated to it. And the teachers plays a fundamental role in trying to avoid this kind of stigma, and making sure that that the insertion, the integration of the children with disability in the classroom is done in a very positive way. But let me stop here and let others also pitch in on any of the questions they would like.
I'm happy to just add.
Thank you so much, Quentin. Let me ask the next so that. Oh. Please go ahead.
Sorry, I just add quickly the question about, or the point being made about referrals when children are identified as needing advanced care. It can be a challenge to ensure that they are accessing that care. We've seen really good results when there is the potential to text or notify caregivers. That's worked very well in terms of reminding them to take their child to the eye health facility if there's something more serious happening with their eye. So I just thought I'd share that. Some ministries have looked into covering the cost of transportation. That gets costly and complicated. And I think that there's been some interesting tests around these reminders, and that there's been good response when caregivers have received those reminders. So I just wanted to share that.
Thank you so much, Elizabeth. So the next question, and this also goes to you, Elizabeth. This is from Fiona. In my line as a teacher, children who have eye problems sometimes have a little problem with hearing. What are some of the NGOs who are into child eye care? So I think this is other NGOs other than yourselves. The other question is this from Hoza. I'm reaching out to know if we have the programs operating in Rwanda and South Africa, and there's another one for South Africa. This again is addressed to you, Elizabeth, if you have programs in Rwanda and also in South Africa. And the final question I'll ask for this round, in the early 20s, 2000, a study by Susan Wedner and colleagues in Dar es Salaam, Tanzania, found that many learners who had been given free spectacles did not have them in school a few months later. This seemed to be mainly due to stigma. So what is other people's experiences to this? I imagine that stigma would be much less of a problem in populations where a much higher proportion of learners have myopia, like, for example, the Asian countries. So maybe you could also speak to that, Elizabeth. Over to you.
Sure. The first question, it sounded like it was about hearing as well as vision problems. Did I get that right?
Yes, that is correct.
So there are, I'm not the best person to speak to the organizations working on hearing, but I'm sure someone else here is. But there are several eye care NGOs that are, well, several, I should say, around maybe 8 or 10 disability and eye care organizations, NGOs that like I said, have been doing this work for many, many years. They are not necessarily, the eye care organizations are not necessarily coordinating with the hearing organizations. But again, that's where it's really, from my perspective, important to center the ministries in this work, because there have been some ministries that are starting to align those hearing and vision screening efforts and really bring those two interventions together. And only really ministries can do that in that cost-effective, efficient way. And so there are some resources, like I mentioned, the screening process where teachers can learn how to screen for both hearing and vision, developed by the WHO, that I can put in the chat when I'm done talking. So I guess my point there is really NGOs are there to support, but this is something the ministries have all the capabilities to do, particularly when the Ministry of Education and Health come together and really co-own. It's too bad Sarah isn't here from Uganda, because one of the things I think is really powerful about their work is that the Ministry of Education is taking a real lead with school eye health and really right there alongside the Ministry of Health and maybe even taking a bigger position. And I think that that's been a really productive way to engage in the work. The Rwanda and South Africa, I believe that the Ministry of Health had been doing some work in Rwanda a few years back, and I don't know the status of it. So I'm not sure if it's a recurring, work where the teachers are continuing to screen for vision problems and provide glasses. I do know there was an effort a few years back. I'm not sure if it's continuing on or if it was maybe a shorter term effort. But I can certainly look into that. And then South Africa, again, led by the Ministry of Health, there has been some really interesting work where the government did a lot of screenings. But the challenge was they'd done a lot of the screenings for vision problems in schools. The challenge was then they didn't have the capacity or hadn't been, didn't have the, the capacity to then deliver the glasses. So that was unfortunate, where a lot of children did receive screenings, but then didn't get the glasses that year. And I'm not sure when the glasses were eventually delivered. And so I think that really just demonstrates the appetite. I mean, everyone here, it's not a surprise that children with poor vision really need to get this intervention of eyeglasses. And both Ministries of Education and Health really see this need. And so I think with South Africa, there's real opportunity to build on that momentum, but then work together to ensure that those children then get those glasses so that they have access to the power of sight restoring eyeglasses. So just to answer your question shortly, yes, I believe there's been work in Rwanda, and there's certainly a lot of interest in South Africa as well. And then stigma, it can be a problem. It's a different, the stigma, for example, in China is a bit different than it is in India, than it is in sub-Saharan Africa. But there is stigma. One really easy thing that we've seen be pretty effective, and it's an interesting sort of simple way to think about this is, so as I was sharing that most children can get their glasses right then after they've been seen by that eye health professional. And so what happens, and I've seen it in person, and it's pretty fun, where there's a lot of kids going back to their classrooms and all of them are wearing their glasses at once. And that, I mean, I can speak from someone who was very young with eyeglasses. I was embarrassed and had a bit of nervousness about wearing those glasses. And so when all those children go back to their classrooms all wearing their glasses at once, we've seen there's just a stronger likelihood that they'll continue to wear them because they're part of a group, they're not on their own. They're with their peers who also received eyeglasses. And so that's just a really nice byproduct of the intervention. Teachers play an important role combating stigma, as do caregivers. And oftentimes the Ministries of Education we've been working with do some work in the classroom, educating teachers, and then also, when there's that capacity, also bringing together parent-teacher associations and really bringing parents and caregivers together to help combat the stigma, because it's a pretty, if you spend that energy and time that combating the stigma, it usually has a really positive impact. But you're right, that is a challenge. That is something that needs to be addressed.
Thank you so much, Elizabeth. You probably mentioned this at the beginning, but maybe if you could just, again, just highlight the countries that iAlliance is supporting at the moment, what we're working with at the moment.
Sure. We began our work in Liberia. Again, the president at the time had asked us to come there. So we began in Liberia. We've now, with a partner organization, again, we're quite small, so we like to partner. With a partner organization, we have been working in Uganda for the last few years, and Sarah's leading a really exciting effort there. Ethiopia has also been working to lay the groundwork for a national scale of school eye health. We've been in conversation with South Africa, but those are the countries where we're actively supporting ministries right now.
Thank you so much, Elizabeth. So, Quentin, there's a follow-up question, and the question is, how do you suggest embedding training for teachers to avoid extra cost?
Right. I mean, I can answer, right? But also, it would be good to hear from the Zambia delegate and the Kibatu delegates, because even some questions are about school eye health. They may also have some suggestions, for example, on issues of stigma and others. But no, I mean, the embedding is very simple. We do a lot of teacher training, and in this case of school eye health, okay, you would just have 2 or 3 hours of additional training that you embed as part of a larger training. So very simple to do, and of course it's much cheaper because you don't have to gather the teachers for only school eye health. So there are economies of scale, right? But the same would be true for children with other types of disabilities. I think it's very important not to go when you do the training of teachers only for 1 or 2 of very specific disabilities, to be a bit broader and to do this cost effectively through embedding in larger trainings. The example that I gave of Ethiopia is one example, but there could be many others. Maybe let's hear a little bit if there are any questions for Zambia and Kenya, or whether they have anything to add to what Liz and I may have said about school eye health more specifically.
Thank you, Quentin. And there is a question about Nigeria. I wanted Moka to take it as he responds also to the issue of integrating or embedding training into the ongoing trainings. So how can schools in Nigeria, particularly schools in rural and low-resource communities, integrate eye health programs into their teaching and support systems to create a safe, inclusive learning environment where learners with visual impairment or undetected eye conditions can participate fully? So this, again, maybe Mr. Moko, because you work at the country level and you do have rural schools, you do have low-resourced communities. So how can we integrate the eye health programs into teaching to support the system and create a safe space for these children? Over to you. Mr. Moka Godfrey, I hope I'm not pronouncing your name incorrectly. Camila, is he still in the audience?
Hello?
Yes, I can hear you.
Are you getting me?
Yes, we are getting you. Please go ahead.
I didn't take the question clearly.
Okay, the first question was to do with how do you embed training on school eye health into the existing training for purposes of saving cost? And I was just relating that to another one who is asking about Nigeria. how can schools in Nigeria, particularly schools in rural and low-resource communities, integrate eye health programs into their teaching and support systems to create a safe, inclusive learning environment? I'm saying because you are based at the country level, you do have rural schools, you do have low-resource communities. So how do you integrate eye health programs into the teaching and support system or other inclusive education programs? Yes, over to you.
Yes, yeah. So for as a country, we have structures, capacity building structures that run at national, provincial, districts, and then zones. So schools are clustered around the zone, and then we have what we call district resource center coordinators who coordinate all the zones in their districts. And then the districts are actually monitored by what we call the provincial resource coordinator. And so when we have a program that we want to run in the in-service programming, we do capacity build the provincial resource coordinators, district resource coordinators, and some selected key zonal resource coordinators who then get to roll out the intended programmings. And the PRCC is there to give the support, and the people from the nation have to follow up to see how the capacity build trainings are happening. And then this is how we get to realize that once the program starts running, especially during the holidays, all the teachers are actually given those skills. So we do also train them in screening, identification, and assessment. That component is how we embed this in the in-service program. But more on the sustainability area, this is how we have also reorganized our colleges of education by reviewing the past curriculum to actually not only focus on the special educational lens, but for them now to be preparing teachers. We have revitalized around the curriculum to focus on inclusive education as a broader area. So beginning 2026, all the teacher training colleges and universities are going to actually be preparing teachers for inclusive education. Previously, it was special education, guidance, and counseling. But now, that is how we hope our area of sustainability will actually be enhanced through that. So for children with eye health, for children with eye problems, like any other, we have a 12 Washington group questions, 12 questions for those 6 main domains, and sight is one of them. So they screen them. Then from that screening, that's when they will move to be assessed in the school inclusion teams at school level. So there in the school inclusion teams, they will try to assess the child and try to give some interventions within the school setting, first of all, before they actually decide to actually make a referral to a health practitioner only when they have failed those interventions at school level. So the school inclusion teams guide what kind of interventions should be provided. So it's only when those interventions fail that further referrals are made. out of school now to the health professionals.
Thank you so much, Godfrey.
Yes.
We're running out of time, but there are still a few questions, and maybe I will pose a question to Ikitabu. So there's a question from James, and it's asking, the presentations express challenges with capacity building of teachers. What teacher training opportunities are there to help the learner with disability better in Africa as a whole? I don't know if you can say something to that. What teacher training opportunities are there to help the learner with disability better in Africa? Ikitabu, if you could respond to this.
I believe we have several colleagues here from Ikitabu, so feel free to raise your hand and enable you to unmute to talk about the programs in terms of teacher training.
All right. Thank you so much. This is Theo Vincent. And thanks, James, for your question. So different NGOs are already offering different training capacity building for teachers, especially in inclusive education. But also it would be good if the government could also adopt these trainings to strengthen the teacher capacity, to train the teachers on how to care for learners with diverse learning needs. Number two, on how to use the materials that the learners needs, and also how to apply universal design for learning in teaching in the classroom, and also inclusive teaching methodologies. And also a bit of, I would say, language assessment, the language of the child and their different needs that needs to be assessed so that you're able to know which specific intervention, which specific materials do we offer to this learner, and what other teaching methods can I use to support the learner. Thank you.
Thank you so much, Susan. Quentin, please go ahead.
Right. I mean, I know that we have to end, right? Because we always end at 5 o'clock, and I think we have concluding comments. But I wanted to mention two things. One, after each series of 3 webinars, we do produce a knowledge kit with lots of links to publications and resources. So we'll make sure we get that done. It will be only in January, early February, but we can make a special effort to list resources that are available on inclusive education, whether it is for visual impairment, hearing impairment, or other areas. And if you are part of this webinar, I saw Sightsavers, for example, I saw some others. If you would like to send us a link to some of the resources that you have, we are very happy to feature them. And the other thing I wanted to mention, on the ICBA website, you just type ICBA, IICBA, and you'll find the website. Under resources, there is what is called the Africa Education Knowledge Platform, which is an interactive search tool to try to be able to identify curated resources. So we have a few on disability, but we'll have more for the knowledge kit. And one thing that we will pay special attention to is to mention what exists in terms of videos, training for teachers, and so on. I mean, there's a lot that is being produced more. We are grateful for that. And we can make sure that all of you get access to that. So stay tuned with the emails that Camelia, Suan in Chinese will send you, because those resources will be made available. Thank you, Yvonne.
Thank you so much, Quentin. Camelia, allow me to give it back to you in case there's a question that was asked in French that I missed. You could ask, and then we will close. Over to you, Camelia.
Thank you so much. Unfortunately, we won't have time, but we have collected all the questions and we'll direct them to the panelists, and hopefully once we receive the answer, we can include that in the knowledge kit that will be made available. Now, please allow me to invite my colleague from UNICEF, Polycarp Otieno, to give us the closing remarks. And UNICEF is a partner, the consortium partner with us as the Knowledge and Innovation Exchange Africa 19 Hub, and who is leading our work on gender and inclusion. So please, Polycarp.
Yeah, thank you very much, Camelia and colleagues. As introduced, my name is Polycarp Otieno, an education specialist with UNICEF Eastern and Southern Africa Regional Office. We're based here in Nairobi. And I just want to thank you very much, UNESCO ICBA, for this opportunity, because I feel extremely schooled today on the issue of inclusive education. So let me begin by sincerely thanking our speakers, that's Quentin, Elizabeth, who I'm pleased to meet after a very long time. Also Godfrey Moka from Zambia, Vincent from Ikitabu, and of course Sarah in absentia. I want to thank them for their insightful presentations. I also want to thank the near 150 participants from across the region who joined us this afternoon for this engagement. The energy that we've seen in the chat has really been incredible. And of course, it gives motivation to organizers to keep preparing sessions like this. As I said, this has been an extremely rich engagement, and I hope like everyone, I hope that just like myself, everyone has been inspired by the insight from the webinar. So a few points that I've just had, and this by no means is going to tell the whole story from the rich discussion. So the first one is that there is a persistent gap that remains for children with disability. The data that has been presented show consistent gaps between children with and without disability. They remain large and structural, and they underscore why inclusive education must remain a priority for our countries. This has been shared across, whether it's the sobering numbers by Elizabeth or those by Quentin. We've also seen that there are scalable school-based models that are emerging. We've had strong evidence that simple interventions such as vision screening and eyeglasses can already lead to immediate improvements in one of the biggest challenges we have in the region, that is learning. The cost-benefit analysis that has been shared by Quentin showed that these programs offer very high returns, and we have to start seeing education as an investment. Elizabeth did remind us that school-based high health programs offer a practical model that governments can integrate at scale. She's given as an example of Liberia, which is a powerful demonstration that when systems take ownership, impacts really accelerate. We've also heard from Vincent, who has highlighted how early sign language learning environments in Kenya, Rwanda, and Malawi are already transforming opportunities for deaf children. We've seen how they've been able to reach hundreds of teachers, thousands of learners, and there is now accessibility to learning materials. And of course, we do not take these achievements for granted. Godfrey from Zambia has reminded us that teacher capacity is the backbone of inclusive education. And in his presentation, he did emphasize that even the most ambitious reform depends on teachers who feel prepared, supported, and equipped to facilitate learning for children with or without disabilities. My own reflections is that if we really mean what we often say of leaving no one behind, then we cannot afford to raise the question of costs only when it comes to children with disabilities. But when it is not children with disability, we are always cheerfully seeking expansion of education. We have to ensure that we walk what we talk. But more generally, the solutions that have been presented here, both by speakers, but also from the chat, one thing that comes out clearly is that they can only thrive in an environment of commitment from government in policy setting and, of course, partners in working in alliance. At UNICEF, inclusive education remains at the heart of our work, and through the KICS Africa 19 Hub, we continue to strengthen evidence on disability inclusion. We continue to support countries to expand learning opportunities for all children, and we also continue to enable peer learning across ministries and partners and governments. We remain committed to working with governments, partners, and communities to ensure that no child, and absolutely no child is left behind, whether because of disability or any other dimension of exclusion. So let me once again thank our speakers for such a rich evidence and country perspective. Also thank our partners, including Alliance, Ikitabu, ICBA, and government colleagues. I also want to thank all participants for the contribution that they brought to this webinar. And finally, I imagine that some of the questions that were posed have not been exclusively responded to, and I've heard Camelia say that we're going to consolidate all this. Indeed, we'll do that, run them through our panelists, and while we'll be sharing the resources that Quentin has just spoken about, we will definitely include responses to such questions. So colleagues, thank you once again for joining us, and we look forward to continuing this important work together. Over to you, Camelia, for the final rites.
Thank you so much. Quentin, would you like to say something? Or?
No, thank you, everybody. It's 5
Yes,
o'clock. We should close.
yes, thank you so much, everyone, for attending our webinar today. Please, if you could respond to the survey about our webinar sessions and give us suggestions or your feedback, that would be greatly appreciated. So this has been our 9th session of the webinar series. For anyone who has attended all 3 sessions of this set on education for health and well-being, will receive a digital certificate of participation, and we'll send that shortly by the end of the month, of course. Again for joining us. We wish you happy holidays, a bit early wishes, but I hope this year has been very fruitful also through our learning opportunities and beyond. Yes, we'll stay in touch. I will share all the resources once they're made available with you, and that's all. Thank you so much for participation, and we look forward to seeing you again next year.
Thank you. Bye-bye.
Bye.
Bye.
Thank you, everyone.
Thank you.
Thank you, everyone. Thank you.
Thank you, everyone.